Okay, now we're continuing with the solutions for interocclusal space problems, and now we're talking about full arch problems. Okay, so we talked about single tooth, we talked about a quadrant, and then we talked about we're going to talk about now the full arch case. Okay, the full arch case, why do we need the interocclusal space for a full arch? These are usually the cases of full mouth rehabilitation. Let's take this case where all teeth are present. This is a case of having all teeth present, okay? What will we do in such case? This is a case that's planned, and this image, I like it because it shows me the differences between different cases. For example, these teeth are worn out with an interruption of curve of Monson, okay? You see here, these are intruded and these are over-erupted. Okay, here we don't have the sphere of Monson applying to these teeth. So this is one of the situations. A second situation will we have the sphere of Monson there, but we need to add to the occlusal table of all teeth, and we want to do an increase in vertical dimension to add to the anterior aesthetics and posteriorly to get this beautiful smile. Third case will we have is when we have limited amount of teeth, maybe a single tooth and a single tooth here. The idea here is to do what? Is to do a good wax up, returning all of the occlusal table, first of all, parallel to the interpapillary line and the alatragus line. So we take a face bow record for this case, and the technician using the face bow record will utilize the face bow record, the occlusal plane, increase the arbitrary occlusal plane. He could have the sphere of Monson plate with him, and he would do a wax up of all teeth according to the curve of Monson. Okay, and then once we do the wax up of all teeth in the correct position, we do the mock up inside the patient's mouth. We try these contacts once more. So we're going to put our Fox plane inside the patient's mouth and check that the mock up is doing and maintaining all of the contacts parallel to the interpapillary line and parallel to the alatragus line anterior posteriorly. Okay, we should in such cases, to avoid problems with the teeth chipping, TMD after full mouth rehabilitation, we have to put back the curve of Wilson, the curve of Spee back to the teeth. So don't make it a flat rehabilitation. You should maintain the curve of Wilson, curve of Spee after the full mouth rehabilitation. Okay? So how do we increase the vertical dimension? If the patient is used to biting on this reduced arch, there are two techniques. First technique is trial and error with mock-up and increasing vertical dimension, and using night guards, using temporary composites, or using the DAL concept. What are the differences between them? Okay, so going back, we'd have an interocclusal space problem because we want to add to the aesthetic of these teeth. The patient is used to biting on these teeth in contacts, so we don't have enough interocclusal space. Sometimes we have the overruption. What are my options to increase the vertical dimension? First of all, is after we do the wax up, we follow the wax up and do temporization, long-term temporization. Okay, the long-term temporaries can be done by composite buildup of the posterior all teeth, or we can use a temporary night guard that has an increased vertical dimension that will allow me to reduce the freeway space. How much can I increase the vertical dimension? Studies have shown 1 to 4 millimeters we can gain from the freeway space. If it was compensated, if it was not compensated, meaning that the freeway space had increased and the teeth have worn out, I don't need to add to the freeway space anything. So I'm satisfied with building up the teeth without altering the freeway space and the resting position of the patient. Okay, so this is using long-term temporization. Okay, the second method is DAL appliances. DAL appliances is a concept where we add some of the teeth. Okay, So this was long-term temporization by composite build-ups or by a night guard that is worn for long-term, and by this we can increase the vertical dimension 1 to 4 millimeters. The dull appliances were used to be fixed, could be removable, where they depend on maintaining occlusal stops anteriorly with keeping the posterior discluded. What will happen that these will over erupt into place, okay? And this is a fast over eruption. It could extend from 2 months up to 6 months. It depends on how quick the patient eruption process is present. The younger is easier than the older patients. So the over eruption will happen, or we could add the fillings or the permanent fixed dull appliance to the posterior. We add build-up. Now what will happen to the anterior? They will over erupt, okay? So it depends on adding to the anterior to over erupt the posterior, or adding to the posterior to over erupt the anterior. It's different depending on the zenith points and what do I want to change. It's not very predictable in terms of how long it takes, and you need to recall the patient multiple times to gain the vertical dimension you want. Once you have gained it and the patient is satisfied with the new occlusal contacts, we do the full map rehabilitation afterwards. So this is in the case of interocclusal space. We need full arch gaining of it. We meant to make sure that once we are doing full rehabilitation, we need to put the teeth back with a curve of Monson, with a curve of Spee and a curve of Wilson on the posterior teeth. So do maintain the presence of the curves to have a treatment that is free of TMD and occlusal trauma of the remaining teeth after the treatment.